Chapter 12. Chapter 12 talks about community mental health, program development, evaluation, and the leadership within it. It starts off talking about Dorothea Dix. So we talked about some of this stuff that we're going to go over through in these first couple of slides. We've already covered it, so I'm going to go over it really quickly. We talked about it in the first couple of chapters. Dorothea Dix was a big advocate. She was the one that started going around trying to provide this understanding and plot of advocacy for how mental health people that were institutionalized were being treated and the conditions in which they were living. That led to many acts and policies and procedures to try to improve the living conditions. And in time, it led to deinstitutionalization, where in a matter of a very short period of time, 500,000 people were just released from their hospitals and expected to attend their community mental health centers for follow-up. One of the things that happened with the institutionalization was the revolving door phenomenon, because people were not able to maintain as well outside without support, without consistency, without direction, weren't able to take care of their own mental health needs. Then they started that revolving door where they were constantly getting hospitalized, constantly coming in. Other things that have happened over time outside of the negative part of the revolving door is that the positive side of it is that we have been able to manage care in ways that we have been able to reduce the stay. Where people used to actually live in an institution, we have been able to reduce the stay to maybe 3 to 5 to 7 days, and that has increased in patient turnover. So hospitals, instead of having residential people, are having a lot of short-term people. 7.67 million persons admitted for mental health treatment annually. So that turnover also talks about that these are not the same people. This is not 767 people. This is each year there's a different, various amount. Some the same, some not the same, but 767 people admitted annually into our mental health facilities for hospitalization. Because of the levels of care and least restrictive environment, the shift to community-based care really tried to focus on decreasing symptoms, maintaining the ability to provide longer-term service without it being residential, and the ability to have multiple teams. So we've talked about all of this. We've talked about in previous chapters. We talked about level of care, about climbing that rung of the ladder. We've talked about providing a school-based, home-based, or office-based services instead of inpatient care. We've talked about these internal and external multidisciplinary teams to work together and help clients. And another thing that we've talked a little bit about is how we talked about the ecological factors, that when we assess someone, we not only take in the account of who that person is at this moment, but all the things that have happened to them and how they developed across time, as well as the prevention and wellness factors that, as mental health professionals, that we try to focus on for self-care and coping skills, which is some of our background of community mental health focus. So that provides us with intervention programs, prevention programs, teamwork where we have collaboration and coordination with other agencies. Okay, the specialty mental health sector talks about like your psychiatric, your psychologist, psychiatric nursing, community-based services, marriage and family. It's the private sector and the community mental health sector that both work with least restrictive community-based services. And then you have your primary care network, where you are in the umbrella of the medical profession, where you're the therapist or clinician that works with the people just within that hospital, and you can And so the primary role for you is just therapy with the population that that hospital or that clinic serves. Human service sector. This is more of what you would think with like social services, school-based counseling, Department of Juvenile Justice, those correctional-based, vocational, educational. The human service sector has really increased their hiring in more of the clinical mental health providers into the human service sector instead of more of criminal justice employees. So you'll see a lot more of that growth as well. And then you have volunteer services, advocacy group, peer-related, walk-in grant services that a lot of communities are trying to combat and meet the needs of the community by. It starts talking about the ability to develop a well-designed program that meets the needs of the community. And it starts off with talking about the first thing that you need to know is what are those needs and wants of the people that you're going to serve. What is it that they need? What are they not getting? What would be the overall needs assessment outcome? Because you have to have that information before you can design a program to meet the needs. You got to identify the needs. And when you're looking at program development, another thing that you're going to be looking at is a mission statement. So the mission statement basically says, this is what we do, this is why we're here. In your required assignment, you're evaluating an agency and you're talking about that agency's population that they serve. You probably may see their mission statements when you're researching them as well. They should talk about what the purpose of why their program exists, what their goals are, why are they different from other programs, how they feel about providing services. It's usually just one or two sentences, and it does help them brand who they are and their outlook on mental health. Not only does programs have to have a mission statement, assess the needs, mission statement, but they also have to have goals. So what are the goals that they want to do? What differences do they want to make? Where do they want to be? Because you can't evaluate a program if you don't have goals to evaluate in the first place. So you have to have goals and objectives, just like a treatment plan for a client. The same goes for the programs that you're developing. You have to have goals that are measurable, realistic, adequate, make sense, because you can't evaluate the program if you don't have goals to actually measure and evaluate. The other reason that we want to evaluate a program is because especially if we're getting grant money, we have to show that we're spending that money and that there's efficacy in it, that we're doing something that benefits someone. You don't want to take all this money, pay all these salaries, have all these people do everything, and then find out that for the last 10 years, you didn't make a difference. You didn't make a dent. So it's incredibly important for when you do this step-by-step description of how you're going to carry out these goals, that the agency is able to show that they're accountable for their outcomes and that what they are doing has efficacy. And they do that through the ability to do program evaluation. And depending on what that agency's goals are, there's tons of ways that we can evaluate programs. Some agencies, like you'll see that they might have like I've worked for places where like whoever walks in the door in May, everybody in May that walks through the door in all their agencies has to fill out an evaluation. You have people that they ask to do surveys. You have people that you can look at demographics or specific things when you run numbers and charts. There's tons of ways. And when it talks about formative or summative, some things are going to be more data driven, some evaluation, or whether it's like actual interviews with people that you've served and really got an understanding in that way. The biggest and most important thing about a program evaluation is that you design that evaluation to actually assess the goals that you wanted to reach in the first place. If you have not ever worked for a grant program or you're starting up a new grant program, some of the things that you're going to have to make sure that you are able to identify is that there is a need and that you have an idea about that need. You have to talk about the exact amount of money that you need, how you're going to go about utilizing that money. You're going to write this extreme step-by-step proposal that talks about how your whole program would be laid out. You submit it. If you get the money, then you start going with your plan. If you don't get the money, they may give you suggestions maybe back about why you didn't receive the money, and then you can revise it and request it again. When you are developing any program, one of the most primary keys to effective program is your supervision, your leadership. A lot of people don't understand that with supervision, we have administrative supervision. These are the people that are our administrators. They keep our doors open. They make sure our liability is covered. They make sure that people in payroll is covered. May make sure that your background checks are in, all that Q&A stuff is done. And then you have supervision in the essence of professional growth, self-care, camaraderie, teamwork, clinical skills. And that falls more under like your clinical supervisor. It's really hard when that supervisor has to wear both hats, and that does happen. But a lot of agencies have really spread out to having those two types of supervisors separated, so that you have a clinical supervisor and then you have an administrative supervisor. So your clinical supervisor is the one that's really going to be working with you on your competence level, ethical practices, how well you're providing your clinical services, making rapport, what you need to learn, extra training, mentoring that you need. Whereas the administrative leadership, they really are mostly focused on how can we make sure that we keep these doors open, how can we avoid any lawsuits, liability issues, and it's just really important to understand that those are two different roles. This leadership style of supervision is more under management, where the other one that we were talking about is more under clinical. The last slide that we have for chapter 12 is talking about different styles of leadership. And it's really important for leadership to recognize that how they treat people, how their personality is, how they respect employees, that is a trickle-down behavior that trickles down to the employee. And when you have an agency where the positiveness trickles down, that's where you're going to get people that are inspirational leaders, intellectually stimulating, allow people to have their own voice. And I have always believed, and I've even wrote papers on servant leadership. And I think servant leadership is the best style of leadership, because a servant leadership doesn't come in and tell you what to do. A servant leadership has the leadership styles that says, how can I help you do your job the way that I need it done? So what can I do to help? How can I assist? So you have to be willing to help people get their jobs done and not just bark demands, because those totally give us two different types of vibes within our workplace. And so the ability to look at people as transformational leaders and start working with people on a level of intellect, on motivation, of respect, of serving each other. You know, if you're in the business of serving the community, serving others, that should start at the top, and that will trickle down. So that's all of chapter 12.